I am really honored to introduce our next presenter. If anyone has done has contributed more for the development of endovascular technology, I'm not sure I know, but Dr. Tim Chuter has been an innovator and has really contributed to the very exciting evolution of vascular interventions, particularly in the aortic area. So it's really with great pleasure and honor that I introduce Dr. Tim Chuter, who is our guest lecturer and will present on endovascular aortic repair, current practice and future directions.
Well, thank you for that kind introduction. I guess that must be why you gave me such a difficult topic. Because if you look at the title for the talk, it really could be the title for the entire symposium. And you have some very high-level people giving you very detailed accounts of just about everything in the field. So where does that leave me? Well, that leaves me just making it up as I go along, as I often do. All right, so, you know, all of the royalty licenses and things have been to Cook, which has been very productive over the years for some of these more complex things. So I, you know, to get around the comprehensive nature of the title, I decided to refocus the topic of the discussion. I'm trying to answer the questions: where are we, how we got here, and what we learned along the way, basically as a way to see where we're going. There's a couple of lessons that spring to mind immediately. The first is that when you're talking about a device performance, you're talking about the performance of the device in a specified anatomy. Bad things happen when the capabilities of the device don't match the challenges of the procedure. The other thing to bear in mind is that everything in this field is device specific. This is not so much technique as it is technology. And you can't generalize necessarily from the lessons that you learn with one device to apply to all of the devices. Now, one of the early lessons that we learned was that animal testing and the in vitro accelerated preclinical testing had severe limitations, partly because we didn't know the boundary conditions of the circumstances, but also because it's very hard to model the behavior of the elderly atherosclerotic aorta. So much of what we learned from early clinical experience. Now, that's not such a big problem in the short term, because you learn short-term problems quickly. A bit more of a problem in the long term, as we demonstrated with some of the Anurex experience. But in the short term, we learned that the delivery system has to be tapered, narrow, flexible, and over the wire just to get the stent graft to the place that it needs to go. And so what can we say about regular, standard infrarenal repair? I mean, clearly, we're not where we were 20 years ago. The results have gotten better, the cost has gotten lower, and I think you can say with confidence that it is safer, if not as versatile or durable as an open repair. But the mortality, morbidity, and debility rates are gratifyingly low, so long as the capabilities of the device are respected. So here's what got us all going. This was the big wake-up call that vascular surgery's sacred cow was about to be slaughtered. You know, this is a great paper and a great man, but the thing to bear in mind is that not one of those cases in the original report was successful. The reason it wasn't successful is you had a stent at the proximal end going into non-dilated aorta between the renals and the aneurysm, but you did not have a stent at the distal end, and you didn't have a piece of non-dilated aorta between the aneurysm and the iliac arteries. And the consequence was that those graft limbs all lifted out of the distal implantation site, and some of them were rescued, some of them failed completely, But this led many people to make profound statements regarding the future of endovascular aneurysm repair. Oh yes, this is a great technique. I expect it will be useful in about 5% of cases, was sort of a typical comment, which of course is complete nonsense, right? But it was applicable to that specific technology, and they were overgeneralizing. So here's the solution, relatively straightforward. The aorta is branched or bifurcated. The stent graft needs to be branched or bifurcated. And that's the sort of the state of the art today. Well, the key thing about the long-term performance of these devices is that they had to do their job in a very challenging hemodynamic environment. The constant pounding of the pulse is destabilizing to just about everything, the structure, function, and position of the stent graft. Here's a model of, actually it's from a CT scan, so it's a realistic representation of the stent graft anatomy. And if you look at the flow-related forces, they're actually quite small. The real force comes from pressure. And what we're talking about is the pressure gradient between what's inside the stent graft and what's outside the stent graft. So stent grafts that actually don't do their job very well, like the early Gore grafts, the early Anurex grafts, which were a bit porous and didn't stop the aneurysm pressurization, were actually getting a little bit of help from the fact that the pressure on the outside was the same as the pressure on the inside. All of the grafts that did their job had to face this hemodynamic pounding or migrate and fail. And the concept of column strength, that is the device sort of standing on its legs, really did not apply to the vast majority of devices, because if they were going to be flexible enough to conform to the aorta, which was usually in these patients tortuous, then they were also flexible enough to collapse and sit down inside the aneurysm. Consequently, we saw lots and lots and lots of migration cases. And nobody shut this down because, well, firstly, it was the best thing that was available at the time. There really weren't a lot of alternatives. And secondly, because the FDA was happy giving regulatory approval based on one-year data. But the outcome was predictably bad. Here's one of the remedies, a suprarenal stent with barbs. Pretty much everything out there has one or both of these features. But of course, not only did the top end come out, the bottom end would also come out, or the limbs would disconnect. And the limb disconnection was more of a problem if the overlap zone between two components was short. Something to bear in mind when you're putting branches into fenestrations. Long, thin limbs are more unstable than short, fat ones. If the stent can move, the stent is hard, the fabric is not, the fabric will fail, especially if it's the apex of the fabric, apex of the stent that's hitting the fabric. If you use nitinol, in the good old days, you'd pick up a stent graft at the booth and the stent would be black. And the reason it was black is because of the titanium oxide. What that meant was it hadn't been properly electropolished. What that meant was it had tiny surface imperfections. Those would become the foci of further corrosion and ultimately complete failure. Well, what about the porosity issue that I just mentioned? The early Gore device, the early Anurex device, they worked initially and then they stopped working. And if you actually went in and reoperated on these things, they would look like a sprinkler in the garden. That led some famous people, Jack Collin among them, to declare that endovascular aneurysm repair was a failed experiment. Seems very silly now, but actually at the time it was not an inappropriate response to the results that people were getting with some of the more crude early devices. Well, why was it wrong though? Well, it was wrong because of this. This is a line from Chitty Chitty Bang Bang, where the old professors in the castle in Bulgaria are trying to make a flying car. And they sing this song, because they haven't been very successful. From the ashes of disaster grow the roses of success. The most important lessons that you ever will learn are the failures. And you can only benefit from those if you're prepared to recognize them and be honest about them. More importantly, other people need to benefit from them, so you need to write them up rather than quietly ignore them. So over the years, we have identified some of the things I listed above, features that were associated with success, and other features that were associated with failure. So that not all the new devices had to go through that process of evolution. They could get to a fairly advanced state just by learning from the failures of other devices. So here were some of the lessons. Barbed uncovered proximal stent for security, polished nitinol stents to prevent corrosion, low porosity graft material, otherwise the thing doesn't prevent pressurization of the aneurysm, low profile delivery, because really, I don't know if anybody can remember the early Ancure and Anurex devices. Those were monsters. And then short-spaced Z-stents to make the thing flexible, because the stents themselves are not flexible, it's the spaces between them that are flexible. So here's a couple of examples of current devices, and they all have those features. But of course, there are unanswered questions. I'm not going to go into the Rumsfeld thing where, you know, there are known unknowns and unknown unknowns. And, there are things that we still don't know. For example, what is the natural history of endotension? Those patients who are 85 years old, nobody wants to operate on them again. They have what looks like a perfect repair, and the aneurysm is now 8 centimeters in diameter. What is the natural history of that? Nobody knows, because nobody has the balls to find out, right? Nobody wants to sit on those folks. I've operated on many of them, and I have very seldom found a good reason when I get into the aneurysm why I'm there. The reason why I'm there is because the patient actually usually got so frightened from all their interactions with physicians that they forced me to do the operation. We don't know, but you need to bear in mind two things. There's a chain of causality, you know, where you put the stent graft in there to eliminate perfusion, and thereby eliminate pressurization, and thereby eliminate aneurysm dilatation, and thereby prevent rupture, right? But that's not the only piece of the puzzle, the pressurization and aneurysm dilatation. The other piece of the puzzle is a separate pathway that involves flow into the aneurysm. If you don't have flow into the aneurysm, that is no endoleak, you're not going to have flow out of the aneurysm, that is hemorrhage into the retroperitoneum. And I have had patients who have ruptured, and I've seen it on their follow-up CT scan. I look at this, I rush upstairs, I say, "Why are you still alive?" And the patient says, "Well, yes, I did have a little pain a couple of months ago. Now that 11 centimeter aneurysm is a little bit smaller, and there's something in the retroperitoneum, but the patient survived that little episode quite well." So since I have several of those patients who are being followed, I really would love to know the answer to that question. Also, the natural history of a type 2 endoleak. There are good data to suggest that type 2 endoleak is a completely benign phenomenon. A little more nervous about that one because there is a source of blood to leak into the aneurysm. Then another open issue is the long-term fate of the neck, and how that plays out in self-expanding devices relative to polymer-filled devices. And I'm talking about things like this. This is a beautiful piece of engineering inside a very nice, flexible, small profile delivery system. But it relies for its seal upon polymer within those two little life tubes up at the top end. That polymer will not dilate. If the neck dilates, you will have a type 1 endoleak. So this device, the Nelix device, they depend upon the same thing. And actually, the manufacturers have, with great glee, presented data again and again, or had the surrogates present data, showing that the neck is much more stable with these devices than it is with a self-expanding device. Well, that's all very well, but you have to bear in mind that they're looking through a fairly narrow window. They're talking about what happens in the first 2 to 4 years after implantation. Well, we all know that the neck expands during that period of time. It expands because it's allowed to expand. The stent graft, when it's oversized, the self-expanding stent graft, is a very compliant object. Only when the stent graft gets to be the same size as the neck does it become a non-compliant object, whereupon it provides some protection to the neck and the neck stops growing. Why do I know? Because we followed this 6, 8 years with Zenith devices and found exactly that. The neck would get bigger until it hit parity with the stent graft, and then it would stop. So this is an open question. These devices have great promise, but if 5 or 8 years down the line the necks start to dilate, then these devices will be bobbing up and down inside the aneurysm. Here's another one, another way of making sure that the neck and the stent graft stay in the same place. It's putting these little screws in. They're no longer part of a system, but part of a freestanding thing. I don't know there's a big role for them, but actually, in those rare cases where you're pulling your hair out, you've got a type 1 endo leak and nobody's been able to fix it, and the stent graft is still right under the renal arteries, you've got no room for an extension. Those little screws can actually help you. Well, what about the more complex stuff? And by complex, I mean stuff that can't be treated with a regular infrarenal stent graft. This is actually one of David Hartley's slides, and it was the start of a very sophisticated talk at the time on complex endovascular methods. The slide that followed this one showed David Hartley without a shirt and with a 4-foot chainsaw to skin the cat. This is something that you perhaps want to bear in mind, that a bifurcated graft is actually a branch graft, and that cuff on the bifurcated graft with its little extension will work just fine in other locations. This was a little over 15 years ago that we did this case. What you're looking at is the postoperative CT that is pretty much mimicking regular anatomy, and our approach hasn't really changed very much since then. We're still using cuffs. These ones are sort of absorbed into the wall of the stent graft, although there are other designs that work equally well and some better in different circumstances. For example, those with the cuffs on the inside work quite well where the pararenal aorta is not dilated. And this is how you do it. You put the thing in with the cuff pointing downstream usually, get into it from above, replace that with a covered stent, line that with another stent. Bingo, there you are. Of course, you have to have extensions proximal and distal to account for the extent of the aneurysm, but if you have that, you can treat from, and I think you'll be hearing more about this later, but you can treat from the ascending all the way through to the aortic bifurcation. You can treat patients with rupture, and you can have sitting on your shelf a supply of stent grafts that will work for lots of people. Here's a device you're going to be hearing a bit more about. I won't dwell on it. But there are all sorts of clever design features in this device that make it work. This was a patient of ours from the thoracoabdominal series who came back with an arch aneurysm. She ended up with prosthetic aorta, basically from the ascending through to the bifurcation. Most interesting thing about her was her pulse, which had a systolic of about 170 and a diastolic of about 30. Clearly, the non-compliance of her prosthetic aorta had something to do with that. That's not the only way you can put branches onto a stent graft, though. You can burn holes, you can have one made for you with holes, and you can use a covered stent to create the branches. And this is a picture from John Anderson, one of the earliest thoracoabdominal repairs using that approach. This is what it looks like magnified up. This is the basic approach. This is the original approach from David Hartley and Michael Lawrence Brown. Basically, what you did is you came up with a catheter, went out through the hole, in through the target artery, and that catheter was what guided you to the target. Without that guidance, you can't get a small fenestration to hit the relatively small orifice of the branch. And then, of course, replace it with a stent to make sure everything stays where it's put. Well, the problem with that approach, or the problems with that approach, you can see here. Number one, you need to use balloon expanded covered stents because self-expanding things just won't secure themselves in that location. The other is that a balloon expanded covered stent is a stiff object, a stiff straight object, partly because the balloons that deploy them are stiff straight objects. That gives you a little bit of instability on its own. So what are the late failures of that kind of approach? Basically, by far and away, the commonest source of late failure, these are incredibly stable devices. The commonest source of late failure is failure of the branch. In our experience, about 10% of cuff-based renal branches occlude. But in other people's experience, about 10% of the fenestration-based branches fail in some other way. They fracture, they migrate, they dislocate, or they occlude. So this is the biggest late occurring problem. Get rid of it and we'll have something that we really can roll out for prime time. This is what the crushed balloon expanded stent looks like. This is an intraoperative shot where we've got a renal to the right that's nice and stiff and straight, and a renal branch to the left that's following a curved path, to put it kindly. Well, the one that went out was the straight one, not the bent one. The bent one was fine. Why is that? Well, if you look at it carefully, you'll see that the straight one was straight because it sort of imposed its will on the renal artery. And the renal artery, once it escaped from the bounds of the stiff straight branch, assumed its previous position with a very acute angulation. Whereas the more flexible graft on the other side actually followed the orientation of the renal artery. So what that made us think was that flexible branches were probably the best way to go. And in the last, it's a little over 2 years now, it's probably 20, 21 months, we've been using Viabahn-Zilver combos instead of our previous Fluency-Woolstone combo. And none of the Viabahn-Zilver combos done in that period have occluded. Now, of course, we don't have long-term results. This is a recent trend. But we've done quite a lot now. Those numbers are statistically significant. Well, what about the other major catastrophic failure of this technique, actually, of any technique of aneurysm repair? It's paraplegia. The technique's pretty safe. You're making small incisions, you don't lose a lot of blood, you don't clamp the aorta, you don't open up the chest. The patients do pretty well. Renal failure, rare. Pulmonary failure, rare. MI, rare. Death, rare. Paraplegia is the one to watch. Now, it's a different kind of paraplegia from open surgery. It tends to be delayed, partial, and reversible. Or at least it is in the absence of embolism. And the reason is this. Despite the presence of a functioning stent graft inside the aorta, there are still intercostal and lumbar arteries. And they're still there because there are lots of collaterals through the paraspinous musculature. And those things reorient themselves very quickly to give you flow. So I said that this is sort of a process of convergent evolution. But I think you can carry the analogy a bit further and say that there's going to be some dinosaurs, some evolutionary dead ends. And I'm going out on a limb here just to point out a couple of them. The most heinous example is the multi-layer stent. And that is being used in massive numbers in places where people are not paying a lot of attention. Brazil, for example. And then the next, chimps, that's, I put that up there as an homage to Roy Greenberg, because he coined that term. Chimneys, periscopes, snorkels. People now like to call them parallel grafts, which of course is not right because they're never parallel. Large fenestrations, well, you can place them by dead reckoning, but they're really not going to be very effective because if blood can flow through a large fenestration into the target vessel, it probably can flow into the adjacent aneurysm. And then hybrid repair, that is a big whack for the kind of patients that we want to treat. Here's a picture. I got this from Stéphane Aulon, who showed this picture at a meeting in France. It's a massive endoleak following a multi-branch repair, then subsequent exploration of that patient and removal of the device from the dead patient. He showed this and was immediately given a cease and desist order by the manufacturers, which put a bit of a chill on his willingness to present. Here's a snorkel. Of course, the problem is the gutter. The more you use, the more gutters there are. But the real problem is that they're not parallel. They're very rarely anything like parallel. And the reason for that is that if you do balloon expanded covered stents, which is what most people do for the branches, you're relying upon the balloon to orient the covered stent. Well, the balloon is a stiff, straight object. It will orient itself with the renal artery, or whatever branch it is you're in. But of course, that's not the same orientation as the aorta. It tends to spiral around the aorta out of the renal branch. So this is what you get, and that gives you even bigger gutters. Here's an example of big fenestrations. These things work, but the endoleak rate is pretty high. And you all know about this. It's great, particularly for the surgeon. I mean, this is just a beautiful thing to do with lots of anastomoses. But it's a tough thing if the patient is there because they cannot tolerate an open abdominal operation. What about some game changers, things that would change my opinion of all of these things? Well, specially developed covered stents for use as branches. Everything that we're using right now was developed for something else. You can't expect them to perform to the exact requirements of endovascular multi-branched aneurysm repair because that's not what they were designed for. Specially developed covered stents for use as snorkels. Again, it's a mistake to condemn the procedure for the failings of a specific version of the device. And I could make you despite the fact that I wouldn't want to do it, I could make you a covered stent that's going to work a lot better as a branch for one of these parallel graft things. You just have to give it something of an elliptical cross-sectional profile. And there's ways to do that. And then ways to prevent or treat type 2 endoleak and endotension. As you saw, that the rates of aneurysm dilatation are really quite high in the general population out there. And there are people who regard aneurysm dilatation as a complete, absolute failure of endovascular repair. Well, I don't actually think that's quite true. I think they're applying a paradigm from the natural history of something else, which is the untreated aneurysm, to describe the behavior of the treated aneurysm. But still, it is a little bit troubling. It would be nice to know what was going on there. What about other factors that we really can't control? The FDA is one. You know, people who are working under IDEs to do these procedures discover, number one, the IDE is cumbersome. Number two, it's expensive. And number three, it's not real. You're pretending to do research just so that you can treat your patients. You're using techniques that have been widely available in Europe for 10 years, that have been used in literally thousands of patients, and you're calling it research. You know, not bad. It means that you're gathering data and publishing, but it isn't an accurate representation of reality. And we all have to face financial limits. The Europeans, from their governments, they don't, you know, they'll say, okay, we'll give you 25 grafts a year. You have to figure out who gets those grafts. Well, here, you have to deal with CMS. Training and regionalization are linked. High volume means good quality. Doesn't matter if you're talking about open repair or endovascular repair. If you're doing a lot, you will do it well. If you're not doing a lot, you will not do it well. That plays into the issue of training, especially in a place where there are very few places with the expertise, with the facilities, and with the caseload to actually do high-level endovascular work. So there's a big transition to be made, and we can't even start to make that transition until the more sophisticated devices are widely available. Thank you.